I don't know how else to do this. I tried doing a screen recording app and it didn't record my mouse. So I will play the audio and you'll be able to see me use the mouse. This is Apollonia Steen, Film Study 1, Rotation 2, Week 2. My patient was a 93-year-old female seen for a post-reduction comparison of a trimalleolar fracture on her right ankle. No removable artifacts are seen on the image. However, an overlying cast is present, reducing detail of soft tissue and bony detail. The right marker is present, and the patient's PII has been removed. The part tube and IR are all aligned. This was the AP supine with the patient in a stretcher with a tabletop IR. The central ray is directed perpendicular to the IR and midway between the malleoli through the cast. Patient positioned supine with her leg extended. Collimation is present to the lateral margins of the ankle to include her distal tibia and fibula and proximal half of the metatarsals. Collimation could have been a little tighter to clip off her toes. Technique used was AEC 65 kVp at 1.58 mass with a negative 1.3 reading in the green. The cast would require a slight increase and could have increased the receptor exposure. The pathology present included a previous trimalleolar fracture, which is an ankle joint fracture that involves the medial and lateral malleoli, as well as the posterior lip of the distal tibia. The radiology report showed minimally improved alignment of the fractured fragments and mildly improved alignment of her ankle mortise, as well as vascular calcifications seen in other views and diffuse osteopenia. That's an indication of past inflammation around a certain joint where bone is weaker than normal, but not so far gone that they break easily, which is the hallmark of osteoporosis. The images were of diagnostic quality. However, patient was unable to obtain a true AP position with her toes pointing upwards and the plantar surface exactly vertical. Patient was rolled onto her left with a wedge sponge placed near her right hip to try to obtain the best AP position for her condition. Radiation safety was achieved by the use of the AEC to terminate the exposure at satisfactory penetration levels. Collimation was used. Student and tech was positioned behind the lead barrier wall. Anatomy seen is her distal tibia, her medial malleoli, which has a fracture, the lateral malleoli, which shows the fracture, the distal fibula, the talus, and the presence of distal 1/3 tibia and fibula, and the proximal metatarsals and medial mortise joint open would show proper positioning. Her medial mortise is partially open due to the fracture and limited patient movement. For the second image, the 93-year-old patient seen for a post-reduction comparison of a trimalleolar fracture of her right ankle had no removable artifacts seen on the image, but her overlying cast is present. Thus reduced the detail of the soft tissue and her bony detail. The right marker is present, and the patient's PII has been removed from the image. The part, tube, and IR were all aligned. This is her medial oblique AP mortise supine in stretcher with the tabletop IR. To obtain this position, the central ray was directed 30 degrees from lateral to medial and midway between her malleoli through the cast to compensate for the patient's condition. The patient was positioned supine with her leg extended, rolled to her left with a wedge positioning sponge placed near her right hip. Collimation is present to the lateral margins of the ankle to include the distal tibia and fibula and proximal half of the metatarsals. Again, collimation could have been a little tighter to clip off the toes and only include the metatarsals. However, because of the angle and distortion, I wanted to be sure to include all anatomy. The technique used was a digital AEC 65 kVp at 1.59 mass with a negative 1.9 reading in the green. However, her cast would require an increase, and I believe this photo image is slightly underpenetrated. Images were of diagnostic quality. However, the patient was unable to obtain a 15 to 20 degree medially rotated position with her toes pointed straight up and plantar surface exactly vertical. So a tube angle of 30 degrees was applied, causing slight distortion and partially opening up the joint, particularly on the lateral side. Radiation safety achieved by use of AEC to determine exposure at satisfactory penetration levels. Collimation evident, students and techs were positioned behind lead barrier wall. Anatomy demonstrated here is the tibial plafond, the medial malleoli with fracture, the lateral malleoli with fracture, the ankle mortise joint, and the distal tibiofibular joint. The presence of the distal 1/3 of the tibia and fibula and proximal metatarsals, and both malleoli, an entire mortise joint open would show proper positioning. For the patient's pathology and positioning, the mortise joint is as open as could be. For the last image of the 93-year-old female post-reduction comparison of a trimalleolar fracture patient, no removable artifacts are seen on image, but the overlying cast is present. This reduced the detail of the soft tissue and bony trabecular markings. The right marker is present, and the patient's PII has been removed from the image. The part tube and IR are all aligned, and this is a medial-lateral projection in the stretcher with a tabletop IR. The central ray is directed perpendicular to her medial malleoli through the cast with a 20-degree angulation applied to minimize distortion and open up the joint space because the patient was unable to rotate her leg fully into a lateral position. The patient was positioned supine with leg flexed and abducted. Patient was rolled to her right side and positioned with a wedge sponge under her left hip this time. Collimation is present. To the lateral margins of her ankle to include the distal tibia and fibula and proximal half of her metatarsals. Again, collimation could have been slightly tighter by another inch or so. Again, because of angulation, I wanted to ensure to include all anatomy. The technique used was digital AEC at 60 kVp at 2.49 mass with a negative 1.0 reading in the green. This image seems to show sufficient penetration. The pathology present included a previous trimalleolar fracture, and her cast would require a slight increase in the mass, which is shown on this image. Also, the calcifications can be seen on this image. The images were of diagnostic quality. However, the patient was unable to attain the true lateral position with the lateral malleoli in contact with the image receptor. Therefore, the patient was rolled to her right hip with the wedge sponge placed near her left hip, and the tube was angled 20 degrees to obtain lateral, and open up the tibio-talar joint. Radiation safety was achieved by the use of the AEC to terminate exposure at satisfactory penetration levels, collimation evident, student intact were positioned behind lead barrier wall, and no retake images were taken. Anatomy seen here is the fibula superimposed over the tibia, the talus, the calcaneus, the navicular, and the base of the fifth metatarsal. Presence of the distal fibula superimposed over the distal tibia, the talus, the calcaneus in profile, and an open tibio-talar joint space show proper positioning.